The topic of this presentation is Pediatric Airway Control and Difficult Airway Equipment. I have no conflict of interest and I have no relationship with any airway equipment company. And in this presentation, there's no special endorsement to a particular airway equipment. I will first talk about the anatomy of the neonatal and pediatric airway and how they are different from the adult airway. Neonates are not miniature adults, and there are significant differences in the airway structures. And during growth, there's progressive transition toward the adult anatomy. And the neonate and the infant, they have relatively large head, protruding occiput, short neck, and relatively large tongue. This picture shows the difference of the airway between an adult and a small child. The left side is an adult, the right side is a small child. You can appreciate that in a small child, they have relatively large head, protruding occiput, short neck, and a higher larynx. In the neonatal infant, the larynx are more anterior and like cephalic. The level is about C3 to 4 vertebrae in the neonatal period, and the larynx descends with growth to reach about C6 in puberty. The implication is that the sniffing is morning air used in adult laryngoscopy may not be applicable in neonates and infants. And also in neonatal infants, the epiglottis are longer, floppy, and U-shaped. Therefore, most of the experts advocate to use a straight blade to lift the epiglottis during intubation. This picture also shows the difference of the infant and adult airway. The left side is the infant airway, the right side is the adult airway. The black shadows represent the space of the airway. You can see that in the infant, the narrowest part of the larynx is at the level of the cricoid ring, while in the adult, the narrowest part is at the vocal cord. Also, babies have a shorter trachea, and the length is about 3.2 to 7 cm depending on the body size. The implication is that the endotracheal tube may displace easily. The trachea is covered with ciliated pseudostratified epithelium that is loosely attached to underlying structures. Therefore, minor trauma can lead to edema. And the airway is of small diameter, and because of the resistance increase with the fourth power of radius, therefore, small edema can lead to large increase in the resistance. And the tracheal cartilage is soft and easier to collapse with negative pressure. However, the angle of bronchi branch is similar with adult. The nasal passage is narrow and therefore it is easily blocked by secretion, swelling, and the nasogastric tube. This picture shows the difference in the positioning of a larger child and an infant. In the larger child, we may need to put padding under occiput. In this picture, O represents oral axis, P represents pharyngeal axis, and T represents tracheal axis. A better alignment of the three axes can help intubation. And in infants, we will need to put padding under shoulder or upper torso, because there's difference in the configuration of the head and neck. And the aim is to have the external ear canal at the level or in front of the anterior aspect of the shoulder. This picture shows the difference in the position of the laryngoscope blade during intubation. In the left side, a curved blade is used. Usually it is used for larger children. The aim is to have the tip of the blade above epiglottis to elevate the larynx. But in neonatal infants, most of the experts advocate to use a straight blade, and the aim is to have the blade below the epiglottis to lift the epiglottis to have a better feel of the larynx. Now we have finished the first part of the presentation. The second part of the presentation is about the equipment that can be used in difficult airway. The first equipment that I'm going to talk about is the Mccoy Blade. The picture on the left side shows the Mccoy Blade. There's a lever system and the tip of the blade is a hinge tip. During intubation, when the lever system is activated, the tip of the blade can be flexed and it can lift up the epiglottis to get a better feel of the laryngeal opening. The next equipment that I'm going to talk about is the video laryngoscope. We are going to talk about three of them. That include Cmac, Glidescope, and Airtrack. One model of video laryngoscope is Cmac. From this picture, you can see that there is a laryngoscope and a screen with an electric cable connecting the two. And the image can be seen in the screen. During intubation, we can manipulate the laryngoscope so that the glottis is in the center of the screen, and then we can manipulate the tube for intubation. The next equipment is the Glidescope. It also have a handle blade and electric cable that connected to a screen. On the left side is same Glidescope with the screen directly connected to the handle. For the comparison of Cmac and Glidescope, some studies have been done, and one study was done by Mosier and colleagues in the emergency department, published in Annual Emergency Medicine, and the conclusion of this study is that in the ED, the Glidescope video laryngoscope and the Cmac were associated with similar rates of intubator success. Another study was done again in emergency department and published in Annual Emergency Medicine, and in this study, when used in the video laryngoscope, the Cmac and the Glidescope resulted in similar first-pass success. The next equipment that we are going to talk about is the air track. You can see that the air track has also a screen and a handle and a blade, and there's a side rail that can accommodate an ED tube. Please notice that in the side rail there's an incomplete ring so that the ED tube can be removed laterally. The different colors signify different size of the air track. So how to insert it? You first load the air track with the ED tube and slide the air track midline around the tongue, and then center the focal cord in the screen, and then push the ED tube, and then the ED tube can be removed in the lateral direction, and then we'll remove the air track in the midline. The next equipment is the gum elastic bougie. The use of gum elastic bougie is like that. We insert the laryngoscope and then insert the bougie into the trachea, and then we ask our assistant to load the ED tube, and then we slide the ED tube along the bougie. This is an airway exchange catheter. There's a lumen inside and there are markings outside. And you can connect an adapter to the end of this catheter to provide oxygen. For the exchange procedure, first we insert this exchange catheter into the old endotracheal tube. Because there are markings, we know how deep that we insert the catheter. And then we slide the old endotracheal tube out, and just like the Saldinger technique in performing central line insertion, we insert the new endotracheal tube along the exchange catheter into the trachea. And if there's any problem in oxygenation, we can connect the adapter to the end of this exchange catheter to provide oxygen. For the airway exchange catheter, there are two types of adapter. This one is for connection to ordinary breathing circuit. This one is for connection of jet ventilator. The airway exchange catheter is hollow for ventilation, and we can connect the adapter this way, and then we connect this to the ordinary breathing circuit for ventilation. The next equipment is the optical stilette. This is a metal stilette that cannot be bent, and in using this stilette, there's no need to insert this whole thing into the trachea. We load the ED tube into this stilette, and then we insert the stilette into the mouth and manipulate it and aim at the laryngeal opening, and when we can have the good position, we can slide the ED tube into the trachea. And then we come to the laryngeal mask airway. This picture shows the classic laryngeal airway, and this is the equipment initially invented by Dr. Archie Brain. This is the anatomy of the laryngeal mask airway. This is the mask with an inflatable cuff and an aperture bar, and these are connected to an airway tube. This is the airway connector, and this is the Invisalign with the inflation balloon here. And when the airway is in good position, you can see that it can just cover the laryngeal opening. This is the epiglotic fold, laryngeal inlet. The epiglotis is here, and the breathing fossa is just covered by the laryngeal mask airway. And when the airway is in good position and the cuff is inflated, it can provide a good seal in providing oxygen and ventilation. Laryngeal mask airway come in different sizes. The choice of the laryngeal mask depends on the body weight. In every laryngeal mask airway, the recommended body weight is printed on the laryngeal mask airway, and also the volume of gas to be inflated into the cuff is also printed in laryngeal mask airway. And there's a black line here to remind the operator that this is to be in the bid line after insertion. This picture shows the method of Lma insertion. One of the methods is to inflate the laryngeal mask airway with the cuff deflated. So the cuff is deflated, the left hand hold the head and adjust the head and neck position. We should make sure the patient is well relaxed, the mouth is open, and we hold the Lma like using a pen with the index finger tip at the junction of the cuff and the airway tube. And then apply beacon, we insert the laryngeal inside the mouth and slide along the hard and soft palate until we get into the position. And then with your left hand to stabilize the Lma and remove the right hand, and then inflate the cuff, and the cuff will be then be in position. These are the maneuvers that can be used when the initial attempts are unsuccessful. They include insert from side of mouth, pull the tongue forward, use a jaw thrust, reposition the head, insert the lumen facing backwards, then rotate at 180 degrees as it enters the pharynx. Slight lateral rotation of Lma, partial inflation of cuff, and the use of a laryngoscope. Some experts prefer to insert the laryngeal mask airway with the cuff partially inflated in the first attempt. So there are two schools of thought. One school of thought, insert the Lma with the cuff deflated. Another school of thought, insert the Lma with the cuff partially inflated. So both schools of thought have their supporters. Lma can also be used as a conduit for intubation. This picture shows an Lma with a fiber optic endoscope loaded with an ED tube, so that after insertion of an Lma, we can intubate by using this method. And then after insertion of the ED tube by using a fiber optic bronchoscope, you can remove the Lma and the bronchoscope, and then the ED tube will be kept in position. This is another picture showing the similar setup. There's an Lma together with a fiber optic bronchoscope loaded with an ED tube that can be inserted into the lumen of the Lma. In this picture, the Lma is connected to a breathing circuit to provide oxygenation during the procedure. This table shows the size of the Lma with the largest ED tube that it can accommodate and the size of the fiber optic bronchoscope that can be used. For example, for size 2.5 Lma, we can use a size 5 endotracheal tube and a size 4 fiber optic bronchoscope. This picture shows the intubating laryngeal mask airway, which is a modification of the original laryngeal mask airway. There are three components: the laryngeal mask airway with a metal handle, the endotracheal tube, and a stabilizing rod. First, we insert the laryngeal mask airway, and then insert the endotracheal tube through the laryngeal mask airway, and then use the stabilizing rod. By putting the stabilizing rod to the end of the endotracheal tube to stabilize the position. And then after stabilizing the position, we can remove the laryngeal mask airway and the stabilizing rod, and to minimize the risk of accidental extubation. The next equipment is the eye gel, which is another modification of the laryngeal mask airway. In eye gel, there is a soft, non-inflatable cuff. There are ergotic rests here, the buccal cavity stabilizer, and the integral bite block, and there's a connector for breathing circuit. And there's a casing channel with the entry here and the exit here. For the insertion of eye gel, we need to open the mouth, make sure the patient is well relaxed, and then insert the eye gel into the mouth until it gets into the position. The advantages of eye gel include the following. The material of the cuff is a gel-like thermoplastic elastomer that can conform to the shape of the breathing fossa at normal body temperature, so that it can provide good coverage of the laryngeal opening. And it is a non-inflatable cuff, with no need to inflate the cuff, and the insertion is easy, and there's minimal risk of tissue compression by overinflation of the cuff. And there's no position change after insertion, and there's no need to insert fingers. The insertion requires less technical skills, and the material is latex-free and for single patient use. And also there's a gastric channel, except for size 1 eye gel. This table shows the size of the eye gel that can be used with respect to the patient size and the maximum ED tube that it can accommodate. If we use the eye gel for intubation, then after intubation, we can remove the eye gel by using a silicone pusher or stabilizing rod with the principle similar to the ILMA. We can also consider using a nasopharyngeal airway if we don't have other equipment. This picture shows different models of laryngeal mask, including the Supreme and the Procil. You can see that both in the model of Supreme and Procil, there are gastric channel for insertion of the gastric tube. And this picture shows the video laryngoscope assisted fiber optic intubation. In this technique, there is a video laryngoscope for opening of the airway, and then another operator uses a fiber optic bronchoscope to insert the AD tube. The advantage of using video laryngoscope assisted fiber optic intubation is because there may be a limitation in fiber optic bronchoscope. In fiber optic bronchoscope, there may be tunnel vision, and the field may be blocked by blood or secretion. And the fiber optic bronchoscope cannot maintain the upper airway patency, and there may be difficulty in passing through a compressed or collapsed airway. By using a video laryngoscope, we can create an oropharyngeal space. But however, the disadvantage is that this technique requires two skilled operators. And this ends the presentation.